My name is Dade Lunsford, and I've been asked to give a brief update on the current status of stereotactic radiosurgery in our field of neurosurgery. And I am giving you this talk based on our experience at our center at the University of Pittsburgh. My conflict of interest of various organizations that I'm involved with. Stereotactic radiosurgery was first coined as a term by Lars Lexell in 1951. He combined a first-generation guiding device or stereotactic frame with an orthovoltage dental X-ray tube and treated the trigeminal ganglion in patients with trigeminal neuralgia. 18 years later, these patients still had significant pain relief. This led to further work in collaboration with Börje Larsen in Stockholm and the final development of the first Lexell gamma knife unit using cross-fired photon beams generated from cobalt-60 sources. Lexell was a creative genius in the field of neurosurgery. I think it's important to understand that radiosurgical modalities in the current generation include linear accelerators with various manufacturers, the gamma knife unit now in its sixth generation, proton beam units, which are increasing in numbers and usually use standard fractionation for delivery of radiation, CyberKnife and Zap knife, both Linac variants used to deliver radiation in a radiosurgical principle. Stereotactic radiosurgery uses a guiding technology combined with a radiation delivery source, and typically it's done in a single session, but may be, under the current terminology, used in up to 1 to 5 sessions. Stereotactic radiation therapy, in contrast, is generally using focused radiation using a mask-based immobilization system and delivering the radiation over a standard fractionation interval, usually in intervals of 25 to 30 fractions. Similarly, stereotactic radiation principles can be used to treat non-cranial targets. Spine, lung, liver, pancreas, and heart are all examples of where it's been used. To use radiosurgery, we typically use either a guiding device, a stereotactic frame that's actually attached to the patient's head, or a plastic molded device that immobilizes the head during the time of treatment. Over the last 40 years or so, more than 1.5 million patients have been treated with the gamma knife alone. We don't know the total number of patients treated with other modality treatment. In our own center, we have now done more than 18,000 patients using various generations of the gamma knife over 35 years for tumors, for functional intervention, and for vascular conditions. Nationwide, this has led to a huge growth in the usage of radiosurgery, and this paper from the CMS database over a 10-year interval in the green line shows the tremendous growth of the number of radiosurgical procedures done in the United States, whereas despite the increasing population, the number of patients who are requiring open surgical resection is relatively a flat line. Talk a little bit about specific indications where this has been a real game changer. One is the treatment of schwannomas in the brain, with the most common example being vestibular schwannomas. In our experience, over 2,000 patients over these years. It is used as a primary management in an increasing number of cases, but has also been used as salvage or adjuvant management in 16% of patients where tumors have been subtotally resected or have recurred despite prior initial microsurgery. This is an outpatient procedure done as wheels in, just like other surgical procedures, all done on the same day and discharged on the same day. And there is no really health restrictions or age restrictions in the treatment of this. The goal is to provide a very precisely delivered treatment that conforms to the 3D geometry of this tumor with very sharp fall off outside of the treatment volume. That is the principle of radiosurgery. And of course, in our earlier experience with this, we found very quickly that this changes what we need to know on how to care for such patients, as we saw that the number of patients undergoing resection significantly decreased as compared to the number of patients undergoing radiosurgery. The goal was to control tumor growth, but also to improve outcomes, including facial neuropathy, the risk of sensory loss in the face, and try to preserve in as many patients as possible hearing at a useful level. And typically, over the course of time, these tumors stop growing or gradually shrink, as confirmed by very long-term follow-up in this. Meningiomas are another major indication for radiosurgery, especially in tumors, which in fact we cannot achieve surgical resection of these tumors without high risk. And radiosurgery in this example of a cavernous sinus tumor leads to tumor regression and cranial nerve stabilization in a large experience. One of the primary initial indications for radiosurgery was vascular malformations, especially arteriovenous malformations, with the goal of obliteration of these AVMs. And typically, it is being used for deep AVMs where surgical options are high risk, for smaller volume AVMs, and ones where we're trying to improve outcomes by limiting risk of collateral damage. But certainly we use it in residual AVMs after prior initial management. It's also being used in symptomatic cavernous malformations located at high surgical risks, typically ones that don't present on a peel surface, to reduce the risk of subsequent bleeding. One of Laxal's original goals, as we said, was to treat trigeminal neuralgia. And in this example, we now focus on the retroglycerian trigeminal nerve target to try to lead to pain relief over the course of time. And thousands of patients have been treated worldwide for this condition. For pituitary tumors, especially those that are remnant after prior surgery, usually by endoscopic transnasal approaches, we no longer use radiation therapy, we use radiosurgery, and for those tumors that extend into the cavernous sinus, this is the ideal option with low risk of new endocrine axis loss over many years of experience and 85 to 90% tumor growth control. And we see, for example, in this non-functional pituitary adenomas with long-term follow-up, the 10-year progression-free survival is 75% of patients. Number one indication across the world really is its role in the treatment of brain metastasis. This has opened the door for neurosurgeons to have extensive additional experience in the management of this problem rather than just conventional radiation therapy or just craniotomy and removal. There's been a great deal of information written about this. It has a very high chance of long-term tumor growth control and can be used for solitary or multiple brain metastasis with equal long-term control of the treated tumor volume. For those patients who still require resection, we can treat this with use Gamma knife, for example, for the tumor bed. And that avoids recurrences in many patients. So over the years, we've been learning about how big a tumor could be treated. We can do it in multiple sessions, so-called hyperfractionated radiosurgery. We don't use whole brain radiation therapy except in the miliary disease cases in those patients with carcinomatous meningitis. We now know much more about the optimal dose per target that's needed to control disease. We find that cranial disease control is very high, but still survival is going to be limited to the patient's control of their systemic disease. But we have converted the cause of tumor progression from brain progression to systemic disease progression. We use radiosurgery for treatment of gliomas, typically ones that have been residual or recurred after initial surgery. But in grades 1 and 2, for those patients with residual disease, we think early radiosurgery makes sense. And for those patients who have failed standard management after resection radiation and typically temozolomide, boost radiosurgery, sometimes followed with Avastin, is a very valuable strategy. For tumors such as this, which are very high risk for resection, we have long-term follow-up in the response of these well-circumscribed astrocytomas. In order to further develop knowledge based on this, the International Stereotactic Radiosurgery Society, which was founded in Pittsburgh in 1991, has worldwide become a very potent source of education related to the outcomes of radiosurgery. And more recently, we have helped to organize and currently are the center of this International Radiosurgery Research Foundation, which has had a focus on sustaining the clinical research and establishing a long-term value for radiosurgery. So what's trending in radiosurgery is certainly wider acceptance from our colleagues, governments, health insurers, and professional organizations. More and more different entities are being treated based on extensive publication that's been created over these last 30-35 years. More and more multi-centered big data pushes are establishing its long-term value. Sometimes there's still confusion about what constitutes radiosurgery versus radiation therapy when done with guidance or stereotactic principles. There is increasingly strong science, but better funding would certainly help to sort out some of the ultimate roles. The main thing to remember is this technology is part of the educational needs of neurosurgeons, and it greatly increases the options that neurosurgeons can offer patients in difficult problems within the brain. If you don't want to use this, you can be sure that other services or other professions will be willing to step in. So over the years, the team development, as we see in many things such as skull-based surgery and radiosurgery, represent long-term principles that are needed to establish the optimal care for patients. Radiosurgery is truly a disruptive innovation in neurosurgery. When it started out, it was thought to be potentially functional neurosurgery only, but now we use it for tumors that are hard to reach or high risk for surgical removal, residual tumors or vascular malformations, and it's also increasingly being used as a primary management for many benign brain conditions and vascular malformations. So I hope that you will continue to be a part of the process and use this in your own education, but also be a part of it as of your future practice. Thank you.